Dear participant, good morning, good evening to you all. I would like to welcome you to our webinar discussing event-based surveillance in the EMR region, progress and best practices. I am Dr. Mahmoud Kaid, Public Health Specialist at GHD Infinite. I will be facilitating this webinar jointly with Dr. Aaron Balaji, who is the Associate Director for Global Health Sciences and the Center of Disease Control, USA. Considering the COVID-19 pandemic that has affected our populations and health system drastically, it is important to discuss the need of event-based surveillance. It can contribute to the rapid detection of acute public health events such as the one we are living today. This is extremely important in low and middle income countries, which may have multiple factors affecting their response, such as poor public health infrastructure, political instability, and high influx of refugees. In today's webinar, we will provide an overview of event-based surveillance for EMR countries and the opportunity for countries to learn from the EBS experiences of others in the region, gain a basic understanding of EBS experiences and current capacity, especially related to COVID-19 surveillance in EMR countries. Of course, and for questions, your questions, the answer will be after the contribution of all speakers at the end of the webinar. So please send us your question in the questions and answer box. Before introducing our speakers and facilitators, let me summarize the results of a poll that have been sent by GHD Infinite in collaboration with the CDC Atlanta and WHO UMRO to a number of the EMR countries as an effort to understand the EBS landscape in the EMR region. The poll included 3 questions about the availability of an active surveillance system that reports clusters and deaths of COVID-19 from communities and from hospitals, and availability of an internet-based, event-based surveillance system in place to scan for unusual, unexpected, or new health events from media sources. And the results, and we received the feedback from so far 9 EMR countries for having, the first question, for having an active surveillance system that reports clusters and deaths of COVID-19 from communities. We received the result as 44% reported having it, 22% have no such system, 33% have it in progress. And for the second questions, which is the availability of the same surveillance from hospitals, we received 88.9% reported that they have it. It is available there, and 11.1% is in progress for having it. And for the question, the last one, as for having an internet-based event-based surveillance system in place, the result were 66.7% reported having it. 22% countries are in progress of developing it, and only 11.1% of the countries don't have it. To start our webinar for now, please join me in welcoming our distinguished speakers and facilitators, Dr. Aaron Balaji, Ms. Sharifa Mirali, Dr. Pierre Napet, Dr. Muntasser Osman, and Dr. Muhammad Al-Faqih. We will provide a brief introduction as we go along before each of their presentations. Now allow me to introduce my co-facilitator, Dr. Aaron Balaji, is an Associate Director of Global Health in the Division of Viral Disease in the National Center for Immunization and Respiratory Disease at CDC. Dr. Balaji leads a team of epidemiologists and laboraticians who work includes setting up early warning surveillance system, information networks, laboratory capacities, and reporting platforms in multiple countries to enable them to be better prepared for the next pandemic if one arises. Dr. Balaji and her team also collaborate and work with other public health agencies such as WHO, Africa CDC, Public Health England, NGOs such as Bath Care and International Federation of Red Cross and Red Crescent. Thank you, Dr. Balaji, for joining us as a facilitator and for your support. And for now, let me introduce the first of our speakers. Our first speaker who will be presenting about the global perspective of event-based surveillance is Ms. Sharifa Mirali. Ms. Sharifa is an epidemiologist with the Global Health Science team within the Division of Viral Diseases at the National Center for Immunization and Respiratory Diseases at the US CDC. She is a subject matter expert in event-based surveillance and early warning and response systems. Since 2016, Ms. Mirali has worked in numerous countries to build and sustain integrated early warning surveillance capacities and expand the global knowledge based on event-based surveillance alongside several regional and global partners. She holds a Master of Public Health degree with specialization in epidemiology and global health. Ms. Sharifa, you have 15 minutes for the presentation and the floor is yours. You can share your presentation, please.
Excellent. Can you see my screen okay?
Yes, we can see it, yes.
Excellent, thank you. Thank you, Dr. Mahmoud. Thank you for the wonderful introduction. And thank you to MFINET for hosting this important webinar. Good morning, good afternoon, and good evening to my colleagues and to those attending this webinar. My name is Sharifa Mirali, and I'm an epidemiologist on the Global Health Sciences team in the Division of Viral Diseases. I have been working in the area of event-based surveillance for 4 years, and today I am privileged to be giving you a brief overview on global perspectives for event-based surveillance. In today's globalized society, a health threat anywhere is a health threat everywhere. The emergence or re-emergence of different diseases, along with the ever-increasing globalization of travel and trade, enables diseases to spread more easily and more rapidly than ever before. Our interconnectedness means that early warning is key for early response to a health threat. The challenges of global outbreaks have shown us that late reporting and late response has consequences. Examples such as the 2014 Ebola outbreak in West Africa and the current COVID-19 pandemic show this. It also demonstrates that early reporting and rapid response to emerging outbreaks can reduce the epidemiological curve by preventing potential cases and preventing potential international spread. Event-based surveillance can be a way to address the challenge of global outbreaks. The international health regulations requires countries to develop early warning and response systems, and event-based surveillance is a component of early warning and response. Event-based surveillance is complementary to indicator-based surveillance. So what is event-based surveillance? Event-based surveillance increases the sensitivity of a surveillance system to capture emerging and re-emerging public health threats with the purpose of detecting public health events early. It is novel in that it shifts reporting from case-based to signal-based. Unlike case definitions, signals are broad. They recognize patterns indicative of emerging public health events, and they are highly sensitive. On the right are 3 different signals that describe the same potential event, a novel respiratory virus. An event such as a novel respiratory virus can be detected in a health facility using the signal, a hospital receiving severely ill patients from the same household in the emergency room. It can also be detected through reports from the animal health sector, such as sudden unexplained poultry deaths in a market and in neighboring communities. And it can also be detected from a community. A school reporting several children absent with severe respiratory illness is one such example. As you can see, signals may come from many sources, including communities, health facilities, through social media and others, and this maintains an all hazards approach. A hallmark of event-based surveillance is immediate notification. Once a signal is detected, it is reported immediately to public health authorities. It is important to note that event-based surveillance does not exist as a parallel system. It is integrated into existing surveillance and reporting structures. The team that I'm a part of, the Global Health Sciences team, focuses our efforts on strengthening event-based surveillance in communities and in health facilities, integrating this into existing surveillance systems. We operate within CDC's Global Health Security Framework, which began as a result of the Global Health Security Agenda. We engage at the country level and at the global and regional levels, and we have collaborated with a number of diverse partners, as you can see here. This figure shows information about some of the countries that we have worked in. In our work across 7 countries, event-based surveillance has covered over 23.9 million people, including 167 districts or subnational jurisdictions that have been trained on event-based surveillance. And this training also includes nearly 25,000 community health workers. Event-based surveillance has led to the detection of over 9,000 events thus far. The next few slides describe the successes that we have seen in event-based surveillance implementation, which demonstrate why it is beneficial. First, event-based surveillance enables the detection of all hazards. Out of the 9,000 plus events that have been detected across the 7 countries that we have worked in, the following are some examples of what has been detected. As you can see, there are a variety of events here. These events are not just restricted to human health, they're not restricted to just infectious diseases, but all have the potential to impact the public's health. The second point I'd like to make is that event-based surveillance enables early detection and rapid response. This data comes from Vietnam's implementation of event-based surveillance. It describes the median time to notification and to response of the events that were detected through event-based surveillance. The WHO recommends that events be notified within 24 hours of detection and be responded to within 48 hours of detection. As you can see, the numbers from Vietnam are well under these recommendations. Finally, event-based surveillance contributes to routine surveillance when integrated. Event-based surveillance implementation has shown an increase in the numbers of events, including both cases and clusters that are reported to the routine surveillance system. This data is from Côte d'Ivoire. From 2014 to 2017, we see an increase in the number of suspected measles and yellow fever cases being reported. We also see an increase in the number of clusters of cases being reported for both of these diseases. This, of course, did not happen by chance. In early 2016, Côte d'Ivoire implemented community-based surveillance, using broad signals rather than case definitions, allowing for the reporting of individual cases as well as clusters of illnesses to the routine surveillance system. In Ghana, the integrated disease surveillance and response is used as the country's routine surveillance strategy. In countries implementing community-based surveillance, or CBS, using signals, as in Côte d'Ivoire, 26%, or 87 of the 335 suspected vaccine-preventable diseases that were reported to IDSR were detected through community-based surveillance. This 26% contribution of community-based surveillance to the routine surveillance system occurred over a period of only 7 months, between September 2018 and March 2019. So we have seen how event-based surveillance can operate. We have also seen the successes of event-based surveillance in a number of countries. But how can it be adapted to meet the challenge of COVID-19? As we know, COVID-19 is an unprecedented global crisis. As of this month, over 41 million cases and over 1 million deaths have occurred globally due to COVID-19. We know that robust surveillance is necessary to limit the spread and manage the risk of COVID-19 as well. In May of this year, the World Health Organization provided interim guidance that emphasizes implementing surveillance that includes cluster detection, the detection of deaths, and detection of cases in healthcare workers. So event-based surveillance enables the detection of COVID-19 by detecting the above signals from multiple sources. The next few slides describe experiences from 2 countries that have enhanced event-based surveillance to enable the detection of COVID-19. We will first begin in Kenya. In Kenya, community event-based surveillance has been operational in 2 counties since September of 2018. In June 2020, community event-based surveillance was expanded to enhance the detection of COVID-19. And this was done in a number of ways. First, 3 signals specifically addressing COVID-19 were added. Then, rapid training of over 2,000 public health staff and community health volunteers took place. Community event-based surveillance coverage was increased to 230 communities and 3 health facilities, covering a population of over 550,000 people. The signals that were added are specific to address the recommendations outlined by the World Health Organization. The first signal addresses travel or importation of disease. It reads, any recent local or international traveler with or without symptoms of respiratory illness. The second addresses contacts. Any person who has recent close contact with a person confirmed or suspected to be having COVID-19 with or without symptoms of respiratory illness. And the third signal addresses clusters, 2 or more cases with a respiratory illness from the same locality or village or social group within 1 week. In Kenya, a similar expansion took place. Event-based surveillance has been implemented in communities and in health facilities in Cameroon since June 2018. The first cases of COVID-19 occurred in February 2020 in the country. In March 2020, 1 month later, event-based surveillance was leveraged to enable the detection of COVID-19 in the country by adding 3 community-focused and 4 health facility-focused signals for event-based surveillance, and the rapid training of public health staff, healthcare workers, community health workers, and key informants in communities. Also, in both Kenya and in Cameroon, call centers were established to ensure rapid reporting of COVID-19 related events. These are the signals currently being used in Cameroon to detect COVID-19. While the signals differ between both contexts, health facilities and communities, they both allow for the detection of clusters, cases with recent travel history, the detection of cases in healthcare workers, and patterns that can facilitate the detection of COVID-19. So in some initial insights on event-based surveillance for COVID-19, leveraging existing event-based surveillance capacity can be easily and rapidly done to detect COVID-19. Context-appropriate signals for COVID-19 address the WHO emphasis on detection of clusters, deaths, and cases in healthcare workers. And the experiences in Kenya and Cameroon demonstrate how the workforce can be rapidly trained to detect COVID-19. In summary, event-based surveillance is an essential component of early warning and response systems. It is readily integrated into existing surveillance systems. Country-level implementation has demonstrated that event-based surveillance works to rapidly detect diverse health events, and that event-based surveillance can be leveraged to enhance COVID-19 surveillance. Thank you very much. I will now turn it back over to the facilitators to continue onwards, and I'm happy to answer any questions that come up in the discussion. Thank you.
Thank you, Sharifa, for your rich in the information of your presentation. And of course, for the questions, it will be at the end of, as already mentioned previously, at the end of the webinar, or after all speakers, they will contribute. So thank you again. And Dr. Aren, this is your time to introduce Dr. Pierre. Please,
Yes.
Dr. Aren.
Thank you. Thank you. It is my pleasure to introduce Dr. Pierre Nabet. Pierre is a medical doctor specialized in biostatistics and epidemiology. He worked as a researcher at Epicenter and in the Pasteur Institute in Dakar, Senegal. His focus at that time was on viral hemorrhagic fevers, nutrition, drug resistance, health information systems, and epidemiological surveillance. In 2006, he joined WHO headquarters to lead a team strengthening national surveillance systems. Since 2017, he has been leading the Health Emergency Information and Risk Assessment team in WHO Health Emergencies Program in EMRO. Dr. Nabet is currently leading the information management pillar in the EMRO team, coordinating the response to COVID-19. Pierre, please take it away.
Thanks a lot, Aaron. Thank you very much for the introduction. Before making the presentation, I would like to thank AMFNet and GHD for this invitation to this webinar. There is a long history of collaboration between AMFNet and WHO. There is also a long history of collaboration between WHO and CDC. And I'm very happy to announce, in fact, that there will be even a closer collaboration with AMFNet and CDC and WHO in the coming months, because specifically on event-based surveillance, because we have a very nice project which aims at strengthening event-based surveillance. But as it was presented by Sharifa, event-based surveillance is not a standalone system. This is something which is integrated. This is one of the components of early warning, and early warning is a component of surveillance. So this is, in fact, a project that aims at strengthening event-based surveillance, which is very often the weakest part of the surveillance system, in order to establish integrated disease surveillance. My presentation is about the development of strategy at the regional level for implementing the integrated disease surveillance in the region. Okay, so I will, of course, all of you know what are the objectives of surveillance system, and I will be very brief about it. So globally, there are two main objectives to surveillance. One, which is to monitor the disease mortality and morbidity in order to help guiding control programs, allocating resources, and this is what we usually call the routine surveillance. And there is another component of surveillance, which is to provide another objective of surveillance, which is to provide timely information to guide the control measures. So this type of surveillance is ensuring that outbreaks are rapidly detected, investigated, responded to, and controlled. And this is what we usually call early warning and response. So this is the graph that is presenting the different components of the surveillance. So you can see that there are these two parts that I described, which is the early warning function and the other surveillance functions, which can be the monitoring of trends, the monitoring of programs, the monitoring of chronic pathologies, etc. And there is this other part, which is early warning. Both need to lead to response, in fact, because surveillance is not surveillance for surveillance, but it is always surveillance for response. And you can see also on this graph that indicator-based surveillance, this is used for both early warning function and the other functions, and event-based surveillance it's more specifically dedicated to the early warning function. As you know also, there are many challenges in surveillance. So in countries, surveillance is fragmented. Very often there is no clear definitions of responsibilities and activities between the different stakeholders, who can be many. There is a problem of data sharing, either vertically or horizontally. So it means either from the health facility to the central level or between the different programs that are in charge of surveillance. There is an artificial distinction between preparedness, readiness, and response, and WHO has some responsibility in it, maybe. There is a high turnover of surveillance staff at country level, and very often surveillance is not really well sustained because it's very dependent on specific donors. So to try to solve these challenges that are faced by surveillance, integrating the different surveillance systems might be a solution. So this is just a slide that is showing the different, the fragmentation of surveillance in the EMR. We have many vertical programs. It can be for meningitis, it can be for TB. There is also a specific system which exists in the region about early warning, which is called EWAR. There is a surveillance system on malaria, and very often these programs don't communicate with each other. The need for integration of surveillance has been expressed by the results of the different joint external evaluation that have been conducted either in the region or in other countries. So the common recommendation about surveillance that we have in the GAE, this is develop and implement integrated communicable disease surveillance and response guidelines, organize an electronic platform notification system for all hazards, provide advanced training for key multidisciplinary surveillance team staff to develop analytical expertise. So this need for integrating surveillance and developing a single platform to communicate the information is very often expressed in the outputs of the GEE. So when we're talking of integrating surveillance, what do we mean? So surveillance, as I said, is made up of two components, which is the routine, which is mainly the monitoring of programs, and EWAR, which is the alert component. Both are made up of indicator-based surveillance and event-based surveillance. But surveillance also is not standalone. Health surveillance is part of the health management information system. So health information management system is much broader than surveillance. It also collects information not only on diseases, but also on the activities of the health facilities, etc. And it doesn't rely only on the passive surveillance system that are implemented, but also on surveys, registries, etc. But what is important to understand, this is that surveillance is not something which is different from health management information system. This is a full component. It's completely included in HMIS. Integration can take different forms. The two main forms, it could be the merging of the various surveillance systems using a single infrastructure, for instance, IT application that would permit to do that. Or it could be also a platform to gather information about diseases of interest, utilizing common sources, personnel, and processes. So it's either the juxtaposition of different surveillance systems which are put together, or it could be something which is much more integrated, using the different sources, the different human resources, and putting them in common. So to understand what could be the integrated disease surveillance in the region, we have a project which is in progress. So also just want to tell you that in fact, in the region, we started discussing about integrated disease surveillance in 2002. But since nothing has been put in place because of many reasons. At the difference of the region, the EMR, Africa, the African region has been able to implement IDSR. So IDSR, which means Integrated Disease Surveillance and Response, is a strategy that has been developed at the regional level. It was established first in 19 4 updates of the strategies that have been made since. Other regions like CIRO or WIPRO have also developed a common strategy, which is called said. And so MRO is really late if we compare it to the other regions, because we haven't been able to establish this integrated disease surveillance, despite the willingness to do it in the early 2000s. So in order to reinitiate this, and this is also mainly because of the COVID outbreak, because during the COVID outbreak, we have seen that in fact surveillance was extremely important. Detection of cases was important, reporting of cases was important, and in fact we have also seen that in fact there is a need to strengthen the different surveillance systems. So as I said, we have initiated this project, and the first phase of the project was to identify what were the published best practices for implementing integrated disease surveillance. So we have made a review of the literature. We have screened almost 4,000 documents, but we have seen that very few experiences are reported in the literature. We have found only 11 experiences that we report. And this is a map of, that is presenting the countries which have reported these experiences. So there are some countries in America. So this is mainly US states, Virginia, Massachusetts, and Arizona. We have some African countries like Botswana, South Africa, Malawi, and Zanzibar. We have also Asian countries. So we were very surprised that in fact very few countries have reported their best practices in implementing IDSR. And what are these best practices? So in fact we can identify 4 categories. So practices to improve the information system. And in fact what was done by these countries to achieve this, it was to review, analyze, and disseminate existing information before revising the system. Another category was explaining how to manage the integration process. And what was clearly said by most of the countries, this is that there is a need for a strong political support. It's not only technical skills that are needed, but really a stronger political support. Another thing is that there is a need to gain adhesion across the programs. So this is done through a wide consultation with all the stakeholders who are involved. And this is also through a pragmatic and incremental approach, which has to be country specific. And then the best practice to deploy the revised system, this is to develop a common IT platform. So we have seen also that in all the countries that have reported the experience in implementing integrated disease surveillance, there was a development of a common IT platform. So what is the project that we have in the region? So as I said, the literature review was the first step and it was conducted. What we are doing right now, we are mapping the different surveillance activities that are conducted in the regional office. So the regional office is supporting the countries. And in fact, what we can see also, what we can say is that the fragmentation that is observed at country level, this is very often also observed in WHO. So in WHO, we have many vertical programs that support the vertical programs in countries. And what we are doing right now, this is to look at these different programs and see how we can better coordinate. So this is what we are doing right now. We are mapping the different surveillance activities. The conclusion of this mapping exercise, it will be a consultative meeting within the regional office, which will lead to the development of a concept note on integrated disease surveillance, and that will permit in 2021 to develop the strategy for integrated disease surveillance at the regional level. And the follow-up will be the development of tools and the support and the adaptation of the support to the adaptation and the implementation of integrated disease surveillance in member states. In parallel to this work, we also working on the technical specifications that are required for an electronic surveillance platform. I say that in fact an IT platform, this is probably a key element for the development of integrated disease surveillance. So at the same time as we are conducting this project for developing the strategy, we have also developed many, with the support of headquarters, guidance to providing details on what should be the specification of an IT platform. We are also finalizing a comprehensive surveillance evaluation toolkit. And we, even if we haven't identified right now what should be the best tool for supporting surveillance, and probably there is no best tool because in fact, countries have different experiences. We are working very closely with the Oslo University on DHIS2 because we think that it is a good tool. And this is a tool that could be proposed to countries that don't have right now a solid IT tool. And of course, as I said, we're implementing strengthening the EBS component of EWA in the EMA countries. So this is a summary of what we have done so far in terms of support to event-based surveillance in the region. So the activity started in 2019. They were interrupted by the COVID outbreak. But what we did, so in terms of event-based surveillance, we have two types of activities. One, this is the strengthening of community event-based surveillance, and Sharifa showed you how important it is. And the other one, this is the strengthening of media scanning. For the first one, community event-based surveillance, we provided specific support to Jordan and to Morocco. And in Jordan, we have supported the development of SOPs for implementing all hazard event-based surveillance. There was already a guidance that was developed in Jordan, but it was specific to respiratory diseases, and we have expanded it to all hazards. And in Morocco, we are also in the process of developing the SOPs, and we have coordinated with CDC, which has provided training modules that have been developed by for EBS, and I would like to thank Aaron for this. They have been translated in French in order to provide the training to Morocco. So it was interrupted by the COVID crisis. So in that sense, the COVID had a negative impact, but it has also a positive impact because in fact, countries have been able to see that in fact, there is a need for strong EBS. And we are currently discussing with the colleagues from Morocco to resume the activities. And the other component, this is the media scanning, and WHO has developed a very strong tool which is called EIOS. And EIOS permits to scan very easily the web in order to identify any public health events which is reported on the web. For 2020-2021, we are already in contact with Afghanistan, Libya, Pakistan, and Sudan for providing this additional support. But other countries have also expressed interest, and we are very open to that. Just a rapid explanation of what EIOS is. So this is a collaboration between WHO and the various stakeholders. So this is a tool that can collect easily hundreds of thousands of articles every day from a broad range of sources. So it includes official sites, official Ministry of Health sites, but also since the COVID outbreak, in fact, we have also included social media. So you know that in fact, a lot of communication from countries is made through Facebook or Twitter. And now the tool has the capacity also to detect information that is communicated through these channels. So EIOS has been, as I showed on the previous slide, has been given already to two ministries of health, which are Oman and Egypt. And any other ministry of health that would be interested in getting this tool will be much, I mean, the request will be much welcome. Thank you.
Thank you, Dr. Pierre, and thank you, Aaron. it was, actually a huge elaboration of the event-based surveillance. Thank you for your contribution in this, great presentation. And if we have some questions, it will be directed to you at the end of this webinar, Dr. Pierre. Now we are moving to the presentations of the countries, and the first presenter speaker from the region will be Dr. Muhammad Al-Faqih. He is the National Surveillance and RRT Focal Point at the National Center of Disease Control in Libya. He has community medicine experience through assessing current services ascertained and expressed by health professionals, the public, and the stakeholders. He also supports decision-making in healthcare and planning healthcare services, including any necessary changes, and educates and empowers people about health issues. Dr. Muhammad has experience in teaching training course for surveillance officers and RRTs. His management experience lies in implementing the structure of surveillance and RRTs in central and local level in Libya. Dr. Muhammad will present about Libyan's country experience with EBS. So Dr. Muhammad, you have 10 minutes. The floor is yours. You can share your screen. Thank you.
Okay, Assalamu alaikum wa rahmatullah. It's okay, Dr. Mahmoud. You hear me, yeah?
Yeah, we can hear you. You can share your screen. Please proceed.
Okay, yes. السلام عليكم ورحمة الله. الحمد لله والصلاة والسلام على رسول الله. The region Libya, I'm Dr. Muhammad Faqih, National Focal Point for Surveillance and Rapid Response Team in CDC. As we know, the main aim for the surveillance is to how to respond. Now, comparison between the other indicator-based surveillance and event-based surveillance, we see the event-based surveillance going forward to rapid action by ongoing risk assessment and take any signal from acute to acute public health events, clarify the alerts, and then for rapid action. While the indicator-based surveillance, even it's lead to response, but in the long-term structures. Surveillance system in Libya after 2014 routine surveillance system program was interrupted because of the war and political conflict. Most of surveillance programs lost function due to armed conflict and political instability. That is why Libya was introduced the early warning alert and response network system, EWAL. EWAL system established in Libya on 2016, collaborated with WHO in 2017. More than 125 reporting sites includes primary healthcare, hospital, and IDPs collective shelters. The system from beginning used electronic devices tablet for submit immediately and weekly reports. Anyone is made up of a network of people who collect information, inform the next reporting level, and implement any necessary control. It has two main concepts, components: an immediate alert component, which signals the early stages of an outbreak, and weekly reporting component, which reports weekly data aggregated by health facility. In theory, all national public health surveillance system should have an aware component to rapidly detect and control disease outbreak and to ensure compliance with the international health regulation regarding public health emergency of international concern. So the primary objective of an event is to rapidly detect and respond to signals that may indicate outbreak and clusters of epidemic-borne disease. In Libya, as we know, it's a big country. The population more than 6 millions. In day one, we start with the data collection. More than 125 reporting sites on hospitals and the primary health care levels. There is a central and local level. The priority of disease, which we notified by aware system, 12 immediately notified disease, and 19 weekly data aggregated. The alert, when it's received from this reporting sites, will verified at peripheral and mainly in the central level. The outbreak is investigation taken away at a local and central level. Also, there is an when we need to laboratory support for confirmation of the alert. There is a referral and governmental laboratories. The NCDC also ongoing with the training for surface officers at local levels conducted in many stations. The last one is the feedback and dissemination of Libyan aware and disease and surveillance bulletin, which is disseminated weekly to stakeholders and decision maker in Libya. Exit strategy, which is discussed now, to how to integrate or exit to the routine surveillance system. This is the structure, how to start the reporting reporting at the surveillance officer receives a phone call from the health unit or community or schools or reports from police of unknown death cases, and then goes to health unit and fills the immediate electronic reporting form according and notifies NCDC by phone. The optimal is to have the health facility unit notify immediately the surveillance officer, who in turn notify the NCDC. This made by phone, by fax, WhatsApp, SMS, email, or any form of immediately notification. In the central level, there is in NCDC the weekly bulletin and reports, data management and clarification and feedback for the surveillance officers about their notification. When the COVID-19 at this time, the e-worm is scaling up in response to COVID, training of surveillance officers and the rapid response team in the use of case definition of COVID-19, data entry and reporting, with the inclusion of private sector hospitals. There is a hotline for community, 195, to receive thousands or from calls and consultations from community about the symptoms and signs of COVID. And then another phone or another hotline, 1448. It's for the rapid response team going to the home to clarify these alerts and notification. Also, we going daily for Facebook or another social media or TV to clarify any rumors or any notification by the media about any signs or symptoms or clusters of the disease of alerts of COVID. By the lab, we have only one lab before the COVID, national level laboratories. Sorry, it's are not fully networked with the surveillance system. Now in October, more than 20 public health or researchers, university and hospital laboratories are involved in the COVID-19 by RT-PCR. The challenges mainly at the time or at the COVID, the strengthening surveillance system is more complicated due to the deficiency of resources and the situation instability. We was in the hard and difficult war for more than 1 year against capital Tripoli, which is difficult to situation to establish this reporting and good surveillance in the war situation. The sustainability of the surveillance is more challenging. The incentive or motivation for surveillance officers is diminished. PPE lacking of PPE supply. Also in the laboratory is the low capacity to make all these specimens which is reached to the lab. The limitations of COVID-19 surveillance, there is underreporting total COVID-19 cases. COVID-19 surveillance is also limited as mild and subclinical cases are usually not seeking treatment. Mainly some social problems because of a lot of patients seems to there is afraid from the stigma for the who is COVID-19. This testing capacity also limited. Cannot make testing for all suspected the tip of iceberg of actually infected COVID-19 cases. Lack of timeliness and completeness of reporting are other problems. Now we enter the COVID-19 fatigue. The surveillance officers and the rapid response team have fatigue after after more than 9 months of busy duties. The quality of surveillance data is limited by several factors, including resources and training. From experience, enhancing epidemiologic surveillance of COVID-19 is a crucial tool for rapid cases detection. COVID-19 is a school for learning for all. Adoption of multiple and complementary surveillance system can ensure broad coverage. Regular evaluation of surveillance system ensure that COVID-19 monitored effectively. Laboratories should decide to implement tests for rapid, accurate diagnosis and early detection with high level of biosafety. We are at the beginning of a new era for a new digital and electronic surveillance. Thank you.
Thank you, Dr. Muhammad, for the great presentation of yours. And we will move now, Dr. Aren. If you can introduce Dr. Muntasir, please.
Yes, thank you, Doctor. So now I would like to introduce our final speaker of the session, Dr. Muntasir. Dr. Muntasir holds a Bachelor of Medicine and Bachelor of Surgery from the University of Gezira, Sudan. He also has a master's degree in science in the field of epidemiology and biostatistics from South Africa. Dr. Muntasir has a broad knowledge and vast experience in the area of communicable disease surveillance, outbreak investigation, control and prevention, including establishing early warning systems. He is currently working as a Deputy of Health Emergencies and Epidemic Control Directorate at the Federal Ministry of Health, Sudan. Dr. Muntasir, the floor is yours.
Assalamu alaikum. Good morning, good afternoon, and good evening. Well, Thank you, Aaron. Thank you, Dr. Mahmoud, and thank you, Infinite, for giving me this opportunity. I will speak about the surveillance system here in Sudan, the event-based surveillance in my country. And can you see now?
We are still not seeing nothing, Dr. Muntasir. If you can be sure that share it.
Okay. Okay, is it clear from my side?
Yeah,
Yes, I can see you.
yes, yes.
Okay. As I mentioned, I will start with the surveillance system here in Sudan since mid of 1970. The surveillance system established in the country with a lot of challenges at that time, reporting from all health facilities through radios and through post. And then during 2002, started this Sentinel surveillance system, and from that moved to more improvement with the IHR that the focus at that time was for 4 diseases, and then after 2005 globally the vision became more broad, so more hands needs for reporting. So in Sudan, since 2016, started developing the event-based surveillance as one of the tools for surveillance. We have here, as I mentioned, Sentinel-based surveillance and event-based surveillance. The guidelines, manuals, and SOPs developed during 2016. By the end of 2017, the focal persons at central level, state level, and also locality level trained. And by the end of 2018, the system started in the country. With the main objective, as we know that surveillance is information for action, and we know that in the indicator-based surveillance, as mentioned by Ms. Sharifa and Dr. Pierre, and also my colleague, Dr. Muhammad Al-Faqi, this informal we have in the event-based surveillance, the informal pathway of the reporting. So this is part of the surveillance that you have also the routine surveillance from the health facilities. The main objective for the event-based surveillance is the same, to reduce the morbidity and mortality from the events that affect the health through early detection and reporting of the events. Specific objectives were to detect early the events with health impact among the communities without healthcare coverage. You know that here in Sudan we have the Sentinel sites, 1,817 Sentinel sites out of 5,000, almost 5,900 plus health facility. So almost the coverage is around 30%. The other specific objective is to improve the reporting of health events at all levels, at locality level, state level, federal level, and even at health facility level. In some areas, the health cadre in the health facility received rumor or received information from the community and report it through the system. Verify and confirm the information in appropriate time and respond appropriately by intervention measures to the events. The essential components for the event-based surveillance, detection, assessment teams that also from different, it is a multi-sector, as we know. The hazard itself can be natural, can be chemical, and also radionuclear. So most of the actions has to be through health, although the outcome is from health, disease, and deaths. So other players has to play also, have to have their playing roles during the verification and investigation, also during the response. And feedback mechanism to from the higher level to the lower level, and also for the sustainability and for improvement of the system monitoring and evaluation. The resources for the event-based surveillance here in Sudan, we have community-based surveillance, almost 4,000, around 4,100 community-based health workers from villages, from areas. This is almost around, although it is 15 states in the system, but this cover only 50% of the communities in the country. We have also incident tracking system, that electronic system, and this reports through the state level focal persons, surveillance officers, to the central level. In addition, we have the points of entry reporting through the health cadre in the international designated points of entry. We have also national and international media. This is through the media. It can be also the mass gathering, Facebook, WhatsApp. This is also one of the tools and one of the areas that looking for with interrupted time, in addition to the rumors and relevant ministries that also sometimes reporting like abortion among animals or other suspicion of chemical transmission to the human, also through institution. During COVID, Sudan also improved the reporting through call center. There is a call center also for reporting through 9090 here at central level, and in Khartoum state level to one. This were the hotline, and through the hotline there were early detection of suspected cases, almost 5,000 suspected cases out of 28,000 suspected cases from the country reported through the call center. All of us know that the type of the events is natural or chemical or radionuclear and also biological. And the flow of the information here in the country is from the resource area. It can be formal or informal, through the community to the health facility, and then to the locality level. Here in Sudan, there are 189 localities in 18 states. And then they report to the states, and from the states to the central level through, we have here mobile phones as a source of reporting from the health facilities, Sentinel sites, health facility, and internet connectivity at the state level and central national level. Information resources of the event-based surveillance. This is the form that required to be filled when any report of events came from informal or formal body. It has to be also filled. All the components, part of these components 9 has to be filled by the who is reporting, and then the others to be filled by the officials after verification, investigation, and confirmation of the events. I will go through the one of the reports, the monthly report of here from the country that include the report of September. We have here a monthly report. During the COVID, we have also the daily report of COVID, in addition to the daily report of events. During the floods, the events, natural events, as you know that in Sudan this year, the highly reporting of floods ever recorded the last 100 years. In these last 100 years, almost more than 800,000 population affected, and all the states affected during this time since September and also in October 2020. So I will go most of this reporting through the events. It is from these floods, and this is national.
Sorry, Dr. Montasser, 2 minutes.
Yes.
Just 2 minutes. Sorry.
Sorry.
Sorry, just 2 minutes for you.
Okay, no problem. This is the weekly reporting events. Almost during this year, 45 events reported. This is the timelines. This is example of September 2020. We have 6 events timely reported within 24 hours were 3, and within 48 hours were 2, and 1 beyond that within 72 hours. Was very late. The report itself, the source of the information from partners, we received this. We have partners from focal persons. From here, you can see that from the focal person, it is only 7, but 7 out of 45. The others from the media, from the community, and from the partners. So the informal way playing the role in this information, and that needs the verification then from the authority. This is the distribution of the events, natural, biological, and man-made. Almost most of it from man-made through the conflict or burning. This is one of the forms for the assessment and verification of this event. The challenge of the system itself, as mentioned also by Dr. Breer, that the turnover of the trained staff at all levels, central, state level, and locality level. And in addition to inadequate communication tools, we have here in the country, internet connectivity mainly uninterrupted at the central and state level. And for the locality and for beyond the locality health facility, we have the SIM card mobile phone network through Sudani, and we know that this is the company, but we have another companies. It is not this not cover all the country, so we have also interruption in the regularity of reporting from the health facility or even from the other community health workers. We have also a regularity of intersectoral assessment, like at the national level, you can find the chemical, the other colleague from chemical, and for radionuclear. But this, it will be very difficult to find it at locality and state level. This is part of the challenge that we faced when verified and investigated some chemical events and radionuclear events in the country. Thank you very much. I wish that within the time.
Yeah, within the time. Thank you. Thank you, Dr. Montasser. Now, actually, we have a lot of questions. We should, start, responding to these questions with the remaining time. And if we will not be able to respond to all questions, there will be an answering for all your questions, and it will be distributed to all participants. So,
Dr. Mohammed, Arun here. Sorry, I'm sorry to interrupt. There's actually a nice grouping of the questions. So if you don't mind, I've just grouped the questions into 2 categories, and we can begin to. Is that okay?
Yeah, you go ahead. Go ahead, Arun. The floor is yours. Yeah.
Thank you. Thank you very much, everyone. Really, I see there are more than 180 participants. There are so many interesting questions in the chat box. So but they group nicely into two broad categories. So I think what I will do is maybe start a question to Sharifa, give her time to answer, give a question to Dr. Pierre, and then also pick up questions for Dr. Mohammed and Muntasir. So let me start with a question for you, Sharifa, from the question and answer box. Um, the question to you is, what are the requirements for event-based surveillance? Staffing, software, organization structure, other.
Excellent. Thank you. Thank you, Arun. Thank you for asking that question. It's a really important question. So in all the presentations, we've seen that event-based surveillance needs to be integrated into existing routine, indicator-based surveillance structures in order to be successful. We're not trying to create parallel structures that will just double the work for everybody. So in terms of requirements needed, firstly, there of course needs to be buy-in. At the national level, there needs to be a prioritization of wanting to have event-based surveillance, not just in the Ministry of Health, but across other sectors. Because event-based surveillance includes all hazards reporting, getting buy-in from the ministries of agriculture, of education, tourism, those involved in border health and border security, all of those are essential. So once we get that buy-in from multiple stakeholders at the national level, the idea is to integrate event-based surveillance into the functions already being conducted at national and subnational levels for surveillance. For example, if there is a state or province or district level surveillance focal point, that individual can be trained on event-based surveillance and conduct them as part of his or her duties of surveillance. So of course that involves training. So training can take the form of integrated event-based surveillance training into regular surveillance training, or into, for example, an FETP type platform. Event-based surveillance training can be conducted as part of surveillance training. And then finally, of course, there needs to be infrastructure. Infrastructure meaning ability to report. This can and should follow existing routine reporting systems. Of course, softwares can also be used in that. For example, DHIS2 is one example of a web-based platform that can be used for event-based surveillance reporting, but that needs to be structured and aligned as part of national guidance. So it should follow the directives of routine surveillance strategies.
Thanks, Sharifa. That actually is a connected question to Pierre. Pierre, there are several questions, but I'll ask you one question, which is related to what Sharifa was just saying. The question was, how do we integrate event-based surveillance into the routine system? And then can you provide an example of a system that integrates event-based surveillance in a routine system? Pierre, to you.
Okay, thanks, Arun. So you know that this is the kind of things that I like. So, so the first thing that I want to say is that in fact, event-based surveillance was quoted in the IHR when they were revised in 2005. And based on that, we have tried to identify what event-based surveillance was, and there was no clear definition of event-based surveillance. So what we did in I think it was 2006, 2007, we gathered a group of experts from different organizations, CDC, European CDC, the Pacific Surveillance Network, many other Public Health England, so many organizations, plus surveillance experts from countries. So we established a technical group, and that technical group developed guidance, and some of the graphs that you have seen on the different presentations are extracted from this guidance. So it was, let's say, the first guidance about event-based surveillance. So in fact, the guidance was not about event-based surveillance. It was about early warning with focus on event-based surveillance. Because in fact, we consider that in fact, we could not disconnect early warning from event-based surveillance, but we had to put a focus on event-based surveillance because it was not well defined. So the problem is, and I read the questions, and there is a question about the confusion of terms, and I fully agree with the question. In fact, the thing is that we didn't want to introduce a new term, and we didn't want to introduce additional confusion. And when we compared indicator-based surveillance to event-based surveillance, we didn't want to make to oppose, in fact, event-based surveillance to indicator-based surveillance, but we wanted to show that surveillance is made up of different components. So we have what we call indicator-based surveillance, which is the usual system which is based on the data which are provided by the health facilities. So this is with sources which have been specifically designed for providing information for human health surveillance. And we have other sources of information which haven't been designed for human health surveillance. It can be, for instance, animal health surveillance. It can be the media. I mean, media are a very good source of information for human surveillance. It can be the communities. The communities, in fact, people are not experts in health, but they can contribute to provide information on health. So this is what we meant by event-based surveillance. So in fact, there is no discussion about integrating event-based surveillance in surveillance system. Event-based surveillance is a component of surveillance system. Why it has to be addressed a little bit differently of indicator-based surveillance? This is because of what I said. The sources are not specifically dedicated to human health surveillance. So it means that there is a mechanism that has to be put in place to filter the information, right? Because the information is very sensitive. It might not be relevant to the health system. So we need to be able to put in place filtering mechanisms in order to know if this information should be kept or not by the surveillance system. But both information that are provided by indicator-based surveillance and event-based surveillance should reach the health system, the national health system, after the filtering mechanism. And then when it reaches the surveillance system, the national surveillance system, it doesn't matter if it was coming from indicator-based surveillance or event-based surveillance. What is important, this is that it provided information that has reached the surveillance system, and then the surveillance system has to manage the information in order to be able to provide the response that is needed.
Yes. Thank you very much, Pierre. I think you answered the other questions as well. I want to reiterate, event-based surveillance is nothing new. It's not different from existing routine surveillance systems. For me, very simply, if information can come from anywhere and that will trigger an action and that will allow the response system to be responsive to whatever's happening on the ground in order to detect an outbreak and be able to contain that. So it's nothing different from whether we call it syndromic or whether we call it early warning systems. The purpose is to be able to detect something early and have a lot of different sources be able to provide that information to the health system. So I do want to then, in the interest of time, we do have a couple of questions to other speakers as well. One question for Sudan is, who are the partners for event-based surveillance in Sudan? Can you just quickly give us a sense of who are you working with to collaborate with for putting event-based surveillance in Sudan?
Thank you for the partner, the main partner that's supporting event-based surveillance in Sudan, WHO as one of the donors. For the partner that contributed to the information, as I mentioned, some relevant institutions and ministries, they report directly if there is some diseases among the animal life. We have the Ministry of Animal Resources that report if they think that this can affect the human. They report, in addition to others like the media, and informally sometimes from the private sectors we receive it from medical doctors, and in addition to community seniors, like sometimes politicians. These are the informal way of reporting for some like health events, like cluster of disease or cluster of abnormal disease, or even like some floods of conflict that sometimes report through the media or officially through our channels, that like conflict between some tribes that need more preparation, more actions if the resources is not available at the area or at the capital of the state, needs more national support at that time. So there are different partners, those all partners playing role in the information in addition to the social media itself. And we have focal person that detecting and monitoring this. And this even informal, it is interrupted. It's not regular like the electronic system that we saw in the regional office or headquarters of WHO and other institutes. Over to you.
Thank you. I think you're re-emphasizing what Pierre and Sharifa are saying as well. It needs multiple stakeholders, and information should be coming from multiple sources for this to work. So one question for Libya quickly. This is a question from me. So you did say one of the challenges has been for COVID-19 surveillance has been underreporting. Can you quickly talk to what are the steps, if any, you're taking to increase reporting for COVID-19 and also part of your early warning systems?
Yes, thank you, Doctor. Which now in CDC and Ministry of Health, we are going to training for more surveillance officers and rapid response teams to include health to help recruit community, schools, and other ministries included in the reporting for our system. This is in the brief.
Thank you. Thank you very much. So Pierre and Sharifa, I just want to ask this question to both of you. Maybe Pierre can go first and then Sharifa. So the countries, some of the questions are, if a country is interested in implementing event-based surveillance, how can they participate in the region? And Pierre, to you, and then maybe Sharifa to finish us.
Okay, thanks, Arun. So, as I said, we have this big project in collaboration with CDC and Antnet in order to strengthen event-based surveillance in the region. So, we have been in contact with many countries, almost all the countries of the region. And anyway, every time we visit a country, we are communicating with the Ministry of Health in order to present the project and to see if there is a need for support. So, for instance, well before the COVID, in fact, some time ago, I went to Sudan to discuss with the colleagues, and I could see that, in fact, there was a strong EBS already in Sudan. There is a community-based surveillance which is established in Sudan. They have developed guidance which was presented, etc. But in fact, Sudan could also benefit from the project. And the project is not, so this is a global project strengthening event-based surveillance, but of course it has to be adapted to each country. So it depends on the state of development of the event-based surveillance already in that country, and then it is adapted to it. So I presented 4 different countries where we supported event-based surveillance. So I presented Oman and Egypt, in which we supported mainly the media scanning component in providing the Ministry of Health with the tool, the IT tool, which is called the iOS. When we went to Morocco, and I can see that Ahmed Regig from the ministry is attending the meeting. In fact, we have seen that, in fact, the different components of event-based surveillance were already present, but they were not well coordinated. So what we have decided in Morocco is to support the Ministry of Health to develop the SOPs, and then to train the different people working on surveillance on these SOPs in order to be able to implement them. When we went to Jordan, there was, as I said, these guidelines were already existing, but they were focusing on some specific diseases. So we extended them to all the hazards. So in fact, this is just a discussion between WHO and the country through the country office. In fact, so this is a request that can be made by the Ministry of Health, by the colleagues in charge of surveillance in the Ministry of Health to the WHO country office. And then the country office will forward the request to us in the regional office. And then we will see, of course, we'll be more than happy to respond to all the requests that are made. Thank you. You're muted, Aaron.
You are muted, Aaron. You are muted.
Sorry. So Sharifa, quickly to you, and then we'll turn it over to Amphinet.
Yeah, there's not much else to add. Thank you, Dr. Pierre. That was a really great overview. All I would add is that, countries that are interested, there's beginning to be a lot more literature available on event-based surveillance, on implementation, on examples of countries that have done it previously. And oftentimes it's a matter of just, going through the literature as a first step, and as a second step, looking inwards and looking at what is available in the country. Oftentimes the infrastructure is there, it just needs to be connected and coordinated. And so that is another step that can be taken for countries that are interested in beginning to implement event-based surveillance, looking at available literature, looking at inwardly to what exists in their countries. And then of course we are available to connect with. As Dr. Pierre mentioned, we have this big project in the EMRA region, and we're happy to provide any support and technical assistance.
Yeah, I will also add, we have a lot of training materials that are freely available. If anybody is interested in implementing and need training materials, we can provide you the link. You can learn, download, or attend any of those seminars through those links. So thank you so much to all the speakers. I'm going to now turn it over to Amphinet, and we have 5 more minutes to close out. Thanks a lot.
Thank you, Aaron. Thank you all your distinguished speakers. At the end of our webinar, and on behalf of the GHD Infinite, we would like to thank you, our speakers and facilitator, Dr. Aaron, for their fruitful contribution, and thank you all for your participation. And for the questions, sorry that we couldn't all questions to be answered in this, remaining time, but we assure you that you will receive the answer and for all your questions shortly after we finish the report in this regard. And last words, I just want to say to you all, stay safe and healthy. Goodbye.
Thank you.
Bye-bye.
Thank you.
Thank you. Goodbye.
Bye, everyone.
Bye-bye.
Thank you.